Thank you very much, ma'am. And it would be quite difficult to follow what Dr. Gaurav said because he has really set the standards high. But I'll try my best. And I would say that whatever I would say, it's actually not inner voice because somehow that inner voice was not coming too well. So I took help from other colleagues at AIMS and outside because I really wanted to understand what are the issues which comes up when we grow up as pediatric cardiologists, especially in modern India. So before we talk further, let's acknowledge pediatric cardiology is highly specialized. It is not easy to grasp all the nuances of congenital heart disease care. Pediatric cardiac care is lifetime continuum of care, both for the patient as well as for the cardiologist or for cardiac surgeon for that matter. Now, thanks to the vision and wisdom of pioneers, as of now, most of the congenital heart diseases are now treatable. While the specialty is still searching for ideal management strategies, we know now we are progressing quite well. India has made tremendous progress. As you can see over here, IMR is now less than 5, but we are far, far away from what US and the West was in 1960s and 70s. And pediatric cardiology has actually exponentially increased, or rather to say pediatric cardiac care has exponentially improved in India over the last 2 decades. And as we can see over here, more and number of people are joining pediatric cardiology. And that is an opportunity as well as challenge. And I'll dwell upon that a little bit. Now, the crisis, however, continues because the discrepancy between the number of children who are born with congenital heart disease and number of children who are getting operated is enormous. The gap is still there and it will stay because the birth rate is still close to 20 and we'll continue to produce a lot of children with congenital heart disease. And as we all know, India is a country within country. And this paradox leads some of the people to say, in some part of the modern India, nowadays we are able to manage funds for almost every child and we can give care to almost every child with congenital heart disease. And we saw that in the previous session. And that is a harsh reality of one part of the country, but the other part is still dealing with some of the TGAs coming not at 14 days, but at 14 months for the first time. The child with congenital heart disease can afford by support from the government, but the families cannot afford that surgery. Eisenmenger syndrome is not at all avoidable complication. And patients are everywhere, but there are not many to treat, both in terms of the surgeons available and in terms of the diseases which are operable. And we know why. What it means to pediatric cardiology in coming years is that we are going to have more traction. Pediatric cardiology is coming to more into focus, and focus is rapidly shifting to quality of care and outcomes. So who becomes pediatric cardiologist in India? Till few years or maybe a decade back, it was mainly a keen adult cardiologist who was the pediatric cardiologist, but the scenario has now changed. That is predominantly the pediatricians who will take up pediatric cardiology, and these are the reasons why we take up. Being a pediatric cardiology, whether you are in India or outside, challenges are common. It's not as rewarding. It's a very, very long learning curve. And as you can see, the required skills are too many. And it actually tells the balance of what we want to say work-life balance. Actually, there is nothing like life. The work extends into life. Now, being in India, being a LMIC, it adds to a few more challenges. A lot of infrastructural, lot of policy issues, lack of awareness among people and professionals, unending spiral of late presentation and suboptimal outcomes is something what we keep on facing on daily basis. And being beginner adds to more challenges. Now, what are those? It starts with the training. Where we leave our young cardiologists or young pediatric cardiologists when they leave the training program is somewhere here, while actually they should be somewhere here. So the inflection point doesn't come. They are very far behind in the curve. What we focus is on the fundamental training, and they do not reach that level of implementational training, and that remains the challenge. And someone said, working in the real world is a different ball game. And the challenge surface in the field when you encounter a patient who is 8-month-old TGA with regressed LV, you don't have answers what to do, what not to do. And you end up having to say, mostly you are the one for everything. not many to discuss diagnostic and management dilemma. And that is what a young pediatric cardiologist faces today in modern India. Evidence-based medicine is lacking. Evidence is hard to come by. Pediatric cardiac centers are far and few. Collaborative efforts are almost unheard of. A lot of scope is there, but we are not tapping that potential. And if you are a pediatric cardiologist, be ready to think on your own because evidence is not there. You have to think and say, I may be right, maybe I am not right. Professional satisfaction is not easy to come by. Cure of CSD is often elusive. Many CSDs demand lifelong care. Suboptimal outcomes are not uncommon. Lack of drugs and therapies available abroad are not available so easily, and it needs perseverance to stay motivated in the field. Job security and remuneration, more we say, less it is, but we know, and I will not be dwelling more on that. I'll just say that almost everybody who is working in the private sector say we deserve more. And that is why some of the questions, some of the debates which we had in last few days are reflection of that question in mind. Why should others do the work which pediatric cardiologists are supposed to do? The next question is, how many hats can I wear? Do I become a fetal cardiologist? Do I act like a pediatric cardiologist? Do I work like intensivist, GOCHE specialist, PH specialist? And it is not possible to do justice with each role. What role do I assume going forward is another question. And when that question comes soon after your training in pediatric cardiology, the obvious question is, not so long ago, I became a pediatric cardiologist, and now you want me to become something more. And that is the feeling of deja vu, which we have had after almost every degree we have had in medical curriculum. Even if I decide to specialize, how do I specialize meaningfully? Where do I train? Will I become overqualified? What will I do with that training? Will I be able to use that training in my clinical practice? And then where are we going? Are we going too fast? It was not so long ago, we had the first dedicated course in pediatric cardiology, which was in 2001. In 2021, we are trying to super sub-specialize, and we are still uncomfortable about it. And this is what we thought, and this is what you get. And in terms of job satisfaction, financial security, and other things, this is what you get. And that is harsh reality of the situation. Other concerns, mostly related to the policy and the infrastructure. No surgeon in sight, let me do what I can do. Let me go to interventions. And that tilts the balance from holistic approach, for which you were supposed to be trained, to holistic approach. And that is the problem. We say that is the problem, but we don't have solutions at hand. But after so many challenges, there is the other side of the coin, and we have to see that as well. There are a large number of patients. We can make a huge impact in the quality clinical training and research. Increasing number of these pediatric cardiologists should have more collaboration and communication. There is scope of better specialization. Research, drugs, device, tools, and techniques, which were previously had a latency before coming to India, is now very well available. Parents, families, pediatricians, and governments are far more aware about the needs of pediatric cardiac care, and that is an opportunity to me. So what can be done to balance this? And I'm not talking about the bank balance. I'm talking about this balance of challenge and opportunities. Some suggestions: train well and treat well. Learn the art and science of communication to avoid a lot of issues related to distress, medical, legal, and other issues. Coordinate and collaborate with the colleagues and the mentors. Introspect often while you move forward. Connect globally, but think locally. And not everything that can be done should be done. What societies should do: exposure in pediatric training programs. And this is what I got from my colleagues who are practicing in pediatric cardiology, that if they had that exposure, probably they would have reached this inflection point earlier, and we would have shortened the time of this curve, shifted this curve to the left. Opportunities for advanced training is something everybody looks for, and interaction among seniors and the juniors is should be much more, and it can be facilitated further. Increase awareness and other things, we are all aware what can be done to improve pediatric cardiac care. A lot can be done by joining hands. Work as a team, targeted approach with some triage principles would be the need of the hour. Practice quality care and help generate evidence base, which could not be generated in the past few decades because of the paucity of people working in the area, and join hands and advocate for other issues which are lingering on in pediatric cardiac care in India. We must not forget where we come from, because it is not enough that we do our best. Sometimes we have to do what is required. And in India, with so many number of unprepared children, affordable care with compassion is what we need. Not coming together is a disaster, I would say, because before you start a war, you better know what you are fighting for. And if we don't use our resources, we are not going to head forward. Also, because happiness comes from what we do, but fulfillment comes from why we do it. And that is what is important for all of us to realize. So ladies and gentlemen, to conclude, I would say being a young pediatric cardiologist in modern India is definitely challenging, but in challenges lie opportunities. And therefore, I would say being a young pediatric cardiologist in modern India is a responsibility that has to be taken on the shoulders, because the footprints which we will leave will be followed by the next generation. Thank you so much for your patient hearing.
Thank you, Saurabh. That